psychiatry is not something mystical. Psychiatry is not something very out of the world. It is just the larger Siamese twin of the original brain medicine.
The biggest takeaway is that instead of fitting people into criteria, you are now more concerned about understanding the process which is causing the distress or the dysfunction. We never had this many number of young women suffering from PCOS. Every young woman you talk about is complaining of dysmenorrhea, PCOS and those related symptoms which are a direct result of an irritated or a challenged brain.
People should start thinking psychiatry as the next radiology or as the next branch of medicine. Anything and everything that was said in the past is a holy truth in psychiatry.
What is that one message that you would want people to know about modern medicines of psychiatry?
So you are actually contesting the idea that these medicines are just symptomatic, and you are
Agreed.
endorsing the idea that these medicines actually are disease modifying. Because with antibiotic, they are not succumbing to eventual illness. They
Yes.
are living longer. They are producing their offspring. Those offsprings are passing these rare variants more and more into gene pool.
In my 40s, I started taking methylphenidate for a lifelong ADHD.
There is a population genetic pool. Population genetic pool always contains large number of common genetic hazards.
We can trust our molecules and understand the science to feel confident to give ourselves the brain which we deserve. Now, people know very well that an orthopedician is somebody who takes care of the more serious bone-related injuries and defects. And as a psychiatrist, I think I feel blessed that science and the best brains in the world are working at making these molecules more and more user-friendly.
What would you say about the brain-based understanding of psychiatry?
One area where a certain amount of misdirection happened is when we started putting too much of emphasis on theoretical psychological processes.
Hello everyone. This is the interview portion of the course. As you know, I am Dr. Bhaskar Mukharjee, a student of Psychiatry and Brain. Nobody very senior to you, just a senior student who has started his journey in the interesting road. Now, here we have Dr. Satyen Sharma, a second generation psychiatrist, a very good friend of mine. He is in the psychiatry for the same duration as mine as a psychiatrist, but he also has experience of psychiatry as a second generation psychiatrist because his father is Dr. Sharma, who has retired from head position of Patiala Medical College Psychiatry Department. So, I would like to know from Satyen that how he has seen the change in psychiatry throughout his 46 years experience in psychiatry.
Yes, and thank you for inviting me to this, Dr. Bhaskar. This is such a pleasure, and when you mention the major changes, we many a times I like to say that a psychiatrist and a psychologist have the same relationship which an orthopedician has with a physiotherapist, right? Because that sometimes is a basic area where people find it difficult to understand what does a psychiatrist do. Now, people know very well that an orthopedician is somebody who takes care of the more serious bone related injuries and defects. But what does a psychiatrist do? Well, a psychiatrist is a doctor who is trained in these tools and these molecules, which I have seen from the time when my father was a student, joined his post graduation in psychiatry. He had three molecules plus ECT, the fourth component,
Yes.
which unfortunately is demonized in popular culture. It is not at all like they show it in movies and series.
Yes.
It's a very peaceful process, and it still has very relevant uses in modern psychiatry.
Exactly.
My biggest understanding of the past 40 years of psychiatry is that our pharmacopoeia, psychopharmacology, has grown from those three molecules to today more than 250, which are core psychiatry molecules. Plus, we have also appropriated old beta blockers, antihypertensives, other groups of drugs which we find can be very useful in
Yes.
optimizing brain function, right? And what has this huge increase in options done is that it has become more and more receptor specific. We now have the liberty, I think we are spoiled for choice, and we can actually choose molecule based on their side effect profile. The effect is already well established. But now, having 30 odd molecules in each so called group of diseases, that gives us the liberty to extremely personalize the treatment.
Yes.
And, many a times I tell people, look, your mobile phone. Now, if you were to say, KG, I want to buy a mobile phone, but then I'll have to go book a phone, and then somebody has to, put a line to my house, and then, I have to get an instrument and permissions for it. We are talking of 30 years back, 40 years back. Today, you just need to put a cellular tower, you need a smartphone, and you are online. Similarly, now you don't need to go into the psychotherapy and finding the entire structure of what is happening in the brain and how the process is started. Now it is simply a function of identifying dysfunction, identifying distress, finding out which process we need to target. And the last frontier, I guess, is the human brain. We don't know a lot, but we know enough to help almost every patient who walks into our OPDs. And as a psychiatrist, I think I feel blessed that science and the best brains in the world are working at making these molecules more and more user friendly. And they actually increase lifespans, they definitely increase quality of life, and they make the life of the entire family better.
Yes.
Right?
That's
So,
true.
so
That's very
that
true.
that's my biggest takeaway in the last 40 years.
And what would you say about the brain based understanding of psychiatry that has started becoming mainstream of psychiatry in last 10 years?
Agreed. When I was a student of psychiatry, for us the DSM 4 text revision, I think when both of us
Yes.
were doing our post graduation, that was the gold
Mainstay.
standard, with which we tried to classify various disorders, and we found ourselves trying to fit patients into those, criteria, and then trying to treat that particular diagnostic label. Now, ever since having come in touch with you and having, started this journey on going deeper into the underlying process rather than just externally observable, behaviors and subjective feelings, the biggest takeaway is that instead of fitting people into criteria, you are now more concerned about understanding the process which is causing the distress or the dysfunction. And when you target the process, one layer behind what is visible, you almost always are able to help the patient better. Right? That is the biggest takeaway. For example, saying that this is psychosis and it is a silo and you have to treat it with antipsychotics. Ever since learning about brain based approach, you now understand it as a continuum of an obsessive compulsive process, which is now slowly from an overvalued idea to taking you to challenging reality.
Yes.
And when you start treating that patient based on that process, obviously your results will become better, right? And I think one of the biggest, one of the starting points which I found for brain-based, psychiatry was the principles of neural sciences by Eric Kandel,
Yes.
right? For any student of psychiatry, because I think, see, like I often love to quote Alvin Toffler on this, that the illiterates of the 21st century will not be people who can't read or write. They will be people who can't unlearn and relearn. And I think it is very important that last 10 years have been revolutionary in psychiatry. And we need to unlearn the very rigid structure of DSM and start learning the processes behind the symptoms. The symptoms are actually fairly irrelevant. The process is more important. And when you target the underlying process, your chances of actually helping the patient become much, much better.
Yes. That's true. Very, very true.
Hmm.
Then, what improvements you are seeing in your patients when you work in this way?
So there used to be a time when you used to make peace with the fact that there will be a certain group of patients who we used to label as treatment resistant and who you would not be able to help. And I think the fault was not in our molecules, but in our understanding of both what the molecules can actually do and in which so-called off-label uses they actually make more sense because now you are targeting the underlying process, right? So overall, my ability to take on more resistant and so-called difficult to treat cases, and by changing the approach, actually giving them better options towards leading a more normal, a more brain friendly life, making the brain more resilient, making the brain more efficient, and overall improving quality of life, that has 100% gone up, right? I find that I do not slip into those ruts and into those episodes of despondency that, oh, maybe I really cannot help this patient at all, and that he is to be labeled as treatment resistant. I think that's one big change. I do not see any patients as treatment resistant, right? And that's again, thanks to one of these, again, my initial books for this was this neurobiology of mental illness. And I would recommend any practitioner, any student of brain to pick up Charny and Nestler's neurobiology of mental illness as a good starting point to understand that, I think one area where a certain amount of misdirection happened is when we started putting too much of emphasis on theoretical psychological processes, and going into, I mean, they're very interesting, of course, and to some extent, they might be useful, in initial years. But once you start sitting and working with patients, you'll understand that your job as an orthopedician, again, using the same analogy, is to fix the underlying cause. And then leave it to the psychologists to start using that new unlocked abilities towards more positive things. Your job is not to do the physiotherapist's work. And the more true you are and the more you increase your knowledge of actual functioning of the brain and actual effect of the molecules, the more justice you are doing to yourself, your branch, as well as the patient.
Yes. So you are actually contesting the idea that these medicines are just symptomatic, and you are
Agreed.
endorsing the idea that these medicines actually are disease modifying.
100%. Like any non-communicable disease.
Yes.
We have diabetes, We have hypertension. We have various types of cancers. We have certain amounts of these hypothyroid function, for example. The die for that is cast in your genetic structure, right? And I think a stressor will only trigger symptoms. It will not cause the symptoms. The symptom causation has already happened at a genetic level. And we need to accept it. When we are talking about psychiatric diseases, we need to see them as genetic vulnerabilities which can be unlocked at any time under stress. Wherever the brain's ability to maintain that equilibrium is being challenged by stressors. And modern life, I think, is a fantastic way of living unnaturally and increasing stress on ourselves. No, the brain is still a hunter-gatherer's brain. It takes millennia for the brain to actually change or evolve. But the last 200 years of human so-called development is actually very stressful for the brain. And it's no wonder that more and more humans are now succumbing to and exhibiting the so-called symptoms of mental illness.
Yes. But that can also be explained in another way. Let's say there is a population genetic pool. Population genetic pool would always contain large number of common genetic vulnerabilities. Common genetic vulnerabilities are those vulnerabilities which would not cause any dysfunctional symptom if they are present singularly.
Right.
A large number of them needs to be present in a person's body to create a dysfunction. These are common genetic vulnerabilities. Now, there are some rare genetic vulnerabilities which, even if present in singular number, can create sufficient disturbance in organ function and balance and create a disease.
Right.
Now, what happens is nature already and always tries to cull this rare gene pool because natural selection makes these people who have this rare gene pool die earlier.
Yes.
They don't pass on their genes. That was the structure till 1920. Why 1920?
Antibiotics.
Because antibiotics
Yes.
came into play.
Yes.
We have done a major revolution. We have created a scenario where natural culling of the vulnerable population is not working because with antibiotic they are not succumbing to eventual illness. They
Yes.
are living longer. They are producing their offspring. Those offsprings are passing these rare variants more and more into gene pool.
Exactly.
If we think about population genetics and if we think about the population genetic calculation, then first these rare genetic variants would start expanding in arithmetic progression.
Yes.
But from 3 to 4 generation onward, the progression would be geometric.
Logarithmic. Yes.
And after 1 or 2 generation, after the third or fourth generation, this would reach to exponential level.
Yes.
So we are the third or possibly fourth generation after 1920. So our offsprings are the generation who are getting the geometrical progression of these rare variant genes. So that is probably why we are getting so much young onset, every non-communicable disease, and young onset, all the psychiatric symptoms.
Agreed.
That is also
Like I like to say that we have actually changed survival of the fittest to survival of even the weakest. That is the function of what we would like to call a civilized society.
yes.
But the downside of it is that now there is a concentration of vulnerabilities
Yes.
in coming generations, and that is a simplest explanation as to why we are seeing this sudden explosion of so-called mental health pandemic or
Yes.
mental health symptoms, especially in the young.
Because
You know?
our diseases are the root of all non-communicable diseases.
Agreed.
Non-communicable diseases of every organ, they start in the brain.
Yes.
Brain's disturbance is the hidden root of this tree of non-communicable diseases.
We never had this many number of young women suffering from PCOS.
Yes.
As we have seen probably in the last 1 decade. I'm sure my gynecologist friends will agree
Yes.
that it's simply it defies logic or logical progression. That it's at a level where almost every young woman you talk about is complaining of dysmenorrhea, PCOS, and those related symptoms, which are a direct result of an irritated or a challenged brain.
Yes.
And like you very rightly said, a concentration of vulnerabilities,
Yes.
which shows the downstream effects in every organ. More and more people now are having sleep issues. More and more people are vulnerable to gut, imbalances. And, again, because social media loves to amplify fads. So gut health suddenly is everywhere.
Yes.
But nobody is talking about the gut-brain axis, which is the root causation. Right? So I do follow your point, and I do agree with that, completely. And we need to start looking at making the brain more resilient.
Yes.
In as a response to, I think it's now becoming part of brain hygiene. And the earlier we are able to catch the symptoms, and thankfully that trend is now changing. Now with more and more celebrities actually endorsing medications, therapy, and a more open attitude towards humans and their natural response to stress. And of course, they may not be talking about the genetic vulnerability, which as professionals we are more in tune with. But I think the right message is going out. That the brain is just another organ.
Yes.
And you need to, take care of the master organ to overall improve health at the cellular level in every organ system. Agreed. That's very important.
So, what else has changed in your practice after understanding the brain basis of psychiatry?
So this is
How do
very
you see patients?
yeah. So this is very interesting, and I'm going to share this. When you become a psychiatrist, almost everybody who you're introduced to, they ask, okay, so read my brain, read my mind, right? That's a running joke. And I used to tell them that, boss, look, I as a joke, I used to say, look, this is work for me. I don't do work when I'm not being paid for it. But the reality is that we were never trained in mind reading. Right? We, of course, out of our own interest, we would learn some bits about micro expressions, body language, things like that. And when I would talk to my teacher, Dr. Bhave, at that point in time, that said, does physical structure, facial expressions, and things like that, do they really add any knowledge to us? And he used to very clearly say that no, Satyen, phrenology has been proven to be a pseudoscience. Right? But now that the approach towards psychiatry has changed, and especially when I got introduced to dysmorphology specifically, dysmorphology is again something I think which every psychiatrist should start exploring. And when I say dysmorphology, I think Smith's recognizable patterns of human malformations, right? That could be a fantastic starting point. So Mace scale, you often talk about the Mace scale of malformations, dysmorphology, facial structures, which part of the face is more prominent, what's the placement of ears, the various ratios between facial features, and with a caveat that this should be applied only to OPD and psychiatric patients, not to the general public. There is a
present we don't have enough database
data, right?
to apply it to normal population.
Right.
That if we apply it to normal population, we are actually going to dilute it.
We will corrupt our data, right?
Yes.
We want to work with people who already at a level of distress and dysfunction, like I love to say that, distress and dysfunction to require attention from a psychiatrist. So this dysmorphology, I think, has been the most rewarding Because you can now, looking at the way the face and body has been created as a result of the genetic unique signature, you can actually surprise people by telling them about certain ADHD oblique OC features oblique impulse control, which is very gratifying for the patient. You almost
Yes.
feel like a like a clairvoyant, right? And that, of course, that increases the patient's faith in the
Yes.
doctor being able to read certain physical science, and it's rooted in very good science.
Yes.
And I think
Because
this is
it
something
gives
which will serve every psychiatrist very well.
because it gives patient three things. Number
Hmm.
one, the idea of a non-biological mind goes out of window
Oh
because
yes.
the brain is there,
Hmm.
the definite proof is there that the traits can be analyzed from the various body structure, so that
Yes.
must be brain. Number one. Number two, we when understand that response of anything, any therapeutic procedure, there is actually a very fine equation. Total effect of a therapeutic application is real effect of that application plus minus expectation of patient from that application,
Yes.
which comes as placebo or nocebo,
Right.
plus minus expectation of patient from the therapeutic environment, which again comes into placebo or nocebo, plus minus understanding of the therapeutic application applier, means the doctors or the medical staffs towards that procedure.
Yes.
That again actually contributes towards the bias, cognitive bias of the therapy provider
Right.
to see how well that is performing or not.
Agreed.
So, by giving the patient a rundown of their character,
Yes.
we are increasing the placebo value of whatever we are going to offer.
Agreed. Absolutely.
So these are the important
Hmm.
here. Number one, increased placebo value. Number two, there is brain and it is irrevocable the proof of brain is there and no mind is there. And third is it increases patient compliance.
Yes. Now, if I were to ask you one message which you would want, see, you have a unique position in Indian psychiatry. You are seen as a teacher, as somebody who has been able to get into the core science of brain health, right? For want of a better word, I don't want to say mental, it seems stigmatizing, it's a bad word. Brain health. What is that one message which you would want our listeners to remember, which we still suffer from hangover of the past. When you say I'll be using some medication, people think of largectal and chlorpromazine induced zombie like state, drooling saliva, no expressions, and that image unfortunately has stuck very strongly, which is unfair. The telephone has changed. The car does not leak radiators. It doesn't heat up anymore. Cars are now becoming smarter and more reliable. What is that one message which you would want people to know about modern medicines of psychiatry?
I would say there should be two different messages.
Hmm.
One message should be directed towards listeners who are not psychiatrists, just normal people or other medical professionals. That they have to understand that psychiatry is not something mystical.
Yes.
Psychiatry is not something very out of the world thing.
Hmm.
It is just the larger Siamese twin of the original brain medicine, which got divided into two incomplete hubs, which are Sam is doing. One is neurology, one is psychiatry. Psychiatry got the bigger deal, but psychiatry needed a huge technological advance to understand its role in overall schema of the thing. And now, thanks to the unprecedented technological development in last 2 decades, we have finally reached a place where we can appreciate the nuances, the complexities, and the healing potential of psychiatry, the branch of medicine that deals with function of the whole brain, function of the brain controlling the whole body, and actually maintaining homeostasis between brain, body, and body with the external environment. So people should start thinking psychiatry as the next radiology or as the next branch of medicine that is going to rule the choice of medicine for next few decades. That is for general population. Now I have a special message for the psychiatrists who are now in training or who have passed their training but still trying to find their footing in their world, or senior ones who have found their footing. Believe nothing, be a lifelong skeptic. Psychiatry, unfortunately, is riddled with axioms, riddled with dictates. Anything and everything that was said in the past is a holy truth in psychiatry. Psychiatry is like a Semitic religion. This book has diseases writing,
Yeah.
and that writing has to be obeyed at any cost. This is not science. This
Yes.
is a blind
Faith.
devotion,
Yes.
blind faith, a religion. Get our subject out of this religion. Make it a science. Question everything. Taste and retest everything that was there in past. Take nobody's talk just based on belief. If you believe me, then believe me after testing what I am saying. I don't demand any form of blind obedience from anyone. And the same way, you should not be showing blind obedience to anything. Be a skeptic, be a lifelong learner, be a lifelong student. That's the only thing that you can offer to our subject.
Since you have mentioned that, I think I want to share this on this podcast. I don't think I'll find a better platform. We now routinely do 3 generations of history,
Yes,
right?
pedigree charts.
Pedigree charts, right? In an effort to try and identify, what could be possible dysfunction which is coming into this person genetically, right? And I have started doing that very honest exercise with myself. And what I want to share currently, I am taking medicines. In my 40s, I started taking methylphenidate for a lifelong ADHD.
Yes.
Which got missed because it was only discovered in the 80s, started teaching in the late 90s. It became mainstream in the 2000s. By that time, I was already in my MBBS and suffering from the MBBS syllabus.
Yes.
I would do extremely well in my vivas. Long answers were a pain for me, right? Today, I'm able to understand that that was actually untreated ADHD.
Yes.
Today, I'm able to address it. I find that my deep concentration is better, right? And I add propranolol to it in the mornings to keep the jitteriness away. At nights, I am taking my Arcamin and I am taking my Vilazodone at 60 milligrams. And I think this is the level of honesty. This is the level of intellectual integrity at which psychiatry has to arrive,
Yes.
where we can trust our molecules and understand the science to feel confident to give ourselves the brain which we deserve.
Exactly.
Right, and this is to a large part, I mean, I'm thankful to you for having identified the processes and having identified the combination which is actually making me, function at the best brain health I have ever enjoyed in my life.
That was just, I would say, a lucky guess, and which ultimately helped you.
Yes, and it's always a process of discovery.
Yes.
Right, even the most experienced psychiatrist with those protocols and that understanding, you can never 100% predict that this particular molecule is 100% going to suit the person.
No,
The
our
human
job
brain,
is always a guesstimate.
yes. So I think setting those expectations in the very first interview with the patient, that this is a process
Yes.
which you have entered. Thankfully, we are spoiled for choice. We have, like I said, we have 30 plus molecules in each category. One doesn't suit you, gives us so much of information as to what possibly will suit you next.
Yes.
But within those 3 months, most patients I have seen, we are able to find a combination which improves quality of life. And increasingly, I'm seeing psychiatry not as a dysfunction to be contained, but as a opportunity to unlock the lesser used muscles of your brain,
Yes.
right? Newer pathways, and to reduce those processes which are causing distress, and to enhance those which can actually unlock certain abilities which you never knew existed. So when your medicine suits you, like any good science, it feels like magic,
Exactly.
right?
And
And you owe it to yourself to give yourself that chance, right?
exactly, we
And
should
yeah,
actually accept that. And also, the thing is, psychiatric drugs are not, fortunately or unfortunately, only those things which are named as psychotropics.
yes,
Because no drug work only in the organ they are intended to work. Calcium channel blockers do not work only on heart or blood vessel. They also work in brain, they also work in various other body areas.
yes,
All the medicines of pharmacopoeia have their systemic action. So all these medicines that are there in pharmacopoeia are in a way brain medicines too. So we don't have even 300 or 400 medication. We have the whole
many more.
pharmacopoeia at
Absolutely,
our disposal.
absolutely. And since you mention it, aging and longevity is these days a trending occupation of the super rich, right? They
Yes.
they want to improve and increase their lifespan, and without any so-called psychiatric label, lithium has been identified as a molecule which actually increases telomere length, which actually increases lifespan, along with metformin, right? These are the two molecules.
There are not two molecules at this moment. Actually, three.
But you remember the time when lithium used to be a dreaded psychiatric molecule
Yes.
with a narrow therapeutic window, and no other practitioner would touch lithium. Even psychiatrists would be a little, very wary of getting those regular blood levels done
Yes.
and maintaining the therapeutic window. And today we are finding out it is actually increasing lifespan,
Exactly.
right?
The thing is not only lithium. There are three forms of life prolongation medication. One is senolytic, which destroys the aging cell. One is xenomorphic, which changes the aging cell back to normal cell. One is xenostatic, which stops aging but doesn't change the cell fate. Now, our antidepressants, they are
The so-called
xenomorphic.
antidepressants.
The so-called antidepressants, they
Yeah.
are xenomorphic. They change old cell to new cell. Our so-called antipsychotics, they are senolytics. Our so-called other medications, for example, let's say that drugs we use as fringe benefit. For example,
Propanolol.
drugs like propranolol.
Right.
It has static effect
Yes.
as well as senolytic effect. Then the so-called stimulants, they are again drugs which reduces the aging considerably. They are probably a combination of senostatic and senomorphic drugs. So all the drugs that we use in psychiatry are drugs which can prolong life. But the problem of this is we need to be scientific enough to prove it once and for all.
Right.
And then we need to present the scientific evidence to the wider audience.
Agreed.
Because unfortunately, in India, we don't have that much research data. We understand more. We see more patients than any other countries except our fellow countries in Southeast Asia.
Right.
But we don't compile that data. We don't come out with papers of our own, viewpoints of our own. We don't come with findings of our own.
Agreed.
That needs to be done. Otherwise, all these would result in idle armchair academics, but it would never reach to that level where it is
Point well taken.
directed.
Agreed. We need to be producing more high quality scientific data.
Yes.
And I know, Dr. Bhaskar, both of us could sit here and probably talk for a few more hours or until the cows come home, because these are topics very close to our heart. But at this point, I think I would want to stop our flow of thought.
Exactly.
And my viewers and people who are listening to this, I would want that they should feed us with certain topics they would want us to talk about in terms of modern psychiatry, modern brain health, and we will try to do justice to it, like in the most scientific, evidence-based manner. Probably share studies and more hard data on it. And I think this would be the right time to stop today's podcast and also invite more suggestions, ideas from our audience in terms of what would they like to pick our brains on, and keep us also a little sharp in terms of finding more relatable, more topics.
Intellectual challenges.
Yes. So thank you so much, Dr. Bhaskar, for taking out the time, inviting me to this place, and thanks to the platform which has actually given us the opportunity to do this. And I look forward to doing it again. But based on, I think, audience demand, we should.
Let's hope audience gives us some more interesting topics and some more interesting and fascinating question which would stimulate us to come up better versions.
Fascinating.
With that,
really look forward to it.
We are closing this podcast. A huge thanks to Conceptual Psychiatry for giving both of us this podcast platform and for giving me a platform where I can talk about brain-based psychiatry without holding myself back and while hoping to reach a wider audience of 1,000 or more people who would get to know what is brain-based psychiatry, and I am hoping some of them at least would be interested to learn brain-based psychiatry more and thus benefiting psychiatry more and more. Grateful thanks from me to Conceptual Psychiatry.
Thank you so much. Thank you.
Thank you.